It's brilliant tonight that we've got Dr. Angus Robinson, who is known to quite a few of us, particularly in the Sussex area, for having been such a strong supporter of PCaSO and helping ourselves in our own cancer journeys. Tonight we're welcoming members from Sussex, Hampshire, and Dorset, the whole breadth of PCaSO. So it's great that everybody can join us, and hope a few more will as well. Um, and Dr. Robinson, your time I know is precious, so we ought to crack on really, so that with your talk.
Good. So thanks so much for the invite. And I think the premise or the request was an update on Stampede, and we've just recently opened Stampede 2 in Brighton and Sussex. So it's good timing. I think we've got 2 patients in and randomized so far. So I've been crazy busy recently, and I've thrown together some slides, and I really hope it makes some sense. But apologies if it's a little rushed. So Stampede, the original Stampede started in about 2005, 2006. And it is relevant to go back and look at it because it did change. The eligibility criteria for Stampede 2 is different to Stampede 1. But it's also, Stampede 1 had a massive impact on what we would refer to as our standard of care treatment for patients. So the standard of care in 2005 for someone with metastatic prostate cancer was purely androgen deprivation treatment, so GnRH analog injections, which switch off testosterone production. And that changed a lot over the years, and I'll show you some slides to demonstrate that before we get on to Stampede 2. The eligibility for Stampede 1 included, the top left box there, the sort of purpley burgundy one, is patients with metastatic disease, which included node positive or locally advanced disease. So you could have had no evidence of lymph nodes, no evidence of metastases, but a locally advanced tumour, a T3 tumour with a high PSA and a high grade of cancer at presentation. Now those patients are not included in Stampede 2. So that's a patient group who are completely separate. In Stampede 1, it was actually just referred to as Stampede at the time. It started off with 5 arms. Lots of people have heard this term multi-arm, multi-system trial. And the 5 arms included the standard of care at the time, which was injection androgen deprivation. Then there was standard of care plus a bisphosphonate, zoledronic acid, docetaxel, celecoxib, a non-steroidal anti-inflammatory, and then some chemotherapy. And then as you go down the charts there, and the timeline is at the top with the years each arm started. Arm G with abiraterone started in 2012. There was an arm looking at radiotherapy to the primary, even in the context of metastatic disease. That started in 2013. Then there was the enzalutamide arm, the metformin arm, and the merger with the patch trial, including the estradiol patches. And then that form of Stampede closed because it was becoming a huge, unwieldy trial to run and to chase up data on. And the follow-up protocols for these patients were complicated and lengthy. And to encourage centres to continue to enter people into the trials, they needed to simplify things quite a lot. So that trial was closed, and hence they opened Stampede 2. But if we just look at some of the changes in the standard of care that Stampede 1 created, because it really was a seminal trial with thousands and thousands of patients going into the trial. One of the first things it demonstrated was that the addition of docetaxel chemotherapy to patients with newly diagnosed metastatic and at that stage hormone-sensitive prostate cancer was beneficial. So at the time the trial was open, 2005, 2006, we'd already got some data saying that docetaxel was useful in patients with hormone-resistant disease, or otherwise known as castration-resistant, but we didn't know whether it was beneficial in patients with newly diagnosed hormone-sensitive disease. And it was. So that changed the standard of care for many patients before the new generation anti-androgen drugs came along. So many patients were given androgen deprivation and chemotherapy as their standard. The next big step in changing the standard of care in Stampede was the use of abiraterone. So I'm sure all of this audience have heard of the drug abiraterone. And it was really the first of the new generation androgen treatments. It works very differently from the newer class of darolutamide, apalutamide, enzalutamide. They're all anti-androgen. They block the receptor, whereas this switches off the production of additional androgens from different parts of the body. But essentially, the outcome was the same for both of these classes of drugs. And abiraterone was trialled in Stampede 1 in, again, two formats, the locally advanced group and the metastatic group, and both were heavily positive. And it was used in metastatic disease for a long time before the enzalutamide came along, and it's been proven to be effective in locally advanced disease. But as again, many of this audience will know, unfortunately, funding streams in England have meant that patients with this locally advanced disease can't get abiraterone. It is licensed and used elsewhere. That's another slide basically showing the same thing, but in this patient, this is combining the results from two parts of the trial, demonstrating the benefit of the abiraterone with prednisolone in patients with high risk but non-metastatic disease. And in all of these curves, for the survival curves for the trials, you want to see that your trial arm is higher than your standard of care arm. So the red is the standard of care and the blue is the standard of care plus abiraterone. The other big change that came from Stampede was the use of radiotherapy to the primary tumour. So we knew that radiotherapy was beneficial in patients with locally advanced disease. Those trials had been done in the 90s, but we didn't know whether giving radiotherapy to the primary tumour, even in those patients where they already had evidence of metastatic disease, we didn't know whether that was beneficial or not. So Chris Parker and the team from the Royal Marsden led on this part of the trial, and the outcome was definitely favourable, but particularly in the patients with what we would refer to as low metastatic burden. Now, this phrase, low metastatic burden, becomes increasingly relevant in the choices that we make as oncologists of what treatments patients should get, and it also becomes relevant in the randomisation in Stampede 2. In patients with high metastatic burden, which is generally referred to as more than 5 metastases, there wasn't a survival benefit to having radiotherapy to the primary. There are other benefits, because you can get some local nasty symptoms from the prostate if it's uncontrolled and it hasn't had radiotherapy, but it didn't impact on survival. Whereas in the low metastatic burden patients, it did. And hence that also has become our standard of care. Now, I think before, again, talking about Stampede 2, it's also useful to know what other trials have influenced our standard of care, my general practice in a patient who's not going into a trial. What's the gold standard treatment? And there are a few of those as well, mostly looking at the other novel hormonal agents or androgen receptor targeting agents, all the different phrases that we use to describe these drugs. And darolutamide is a good example of that. Now, darolutamide has been through a couple of trials in the patients in hormone-sensitive disease, so newly diagnosed patients with metastatic disease. One of those trials was with chemotherapy, with docetaxel, and one of those trials was without chemotherapy, so just a doublet treatment. And both of them demonstrated a significant improvement in control and survival if you added in darolutamide to whatever your standard of care was. And similarly, we've got the Enzamet trial, which was doing exactly the same thing, but a doublet treatment, but this time using the enzalutamide drug, which was probably the first one out of the blocks after abiraterone. And again, this showed that if you added enzalutamide to your standard castration treatment, your GnRH treatment, then you can improve the long-term outcome and delay the onset of resistance and improve prognosis and survival. The other bit it's relevant to just touch on before then showing you the flow chart for the Stampede 2 is what are the trials that have been done to develop what is now the experimental arms in Stampede 2. So there are two key experimental arms in Stampede 2, one of which is lutetium treatment, and the other is what we call metastasis-directed therapy. It's not a very easy thing to say, but I'll come to that in a second. So lutetium treatment is treatment targeting the PSMA protein on the surface of a cancer cell, and specifically a prostate cancer cell, because that's where they are expressed. And the key trial that demonstrated the benefits of lutetium, a radioligand therapy, was the VISION trial, which came out about, must be 6 or 7 years ago by now. This trial was in the context of patients who had advanced hormone-resistant disease. So they'd been through doublet treatments, they'd probably had chemotherapy, and they were running out of options. And in this trial, they were randomized to either standard of care at that stage, which, to be fair, wasn't that many more treatments, or they got the lutetium treatment. And there was a significant benefit and a survival improvement if you had the lutetium treatment. Hugely expensive treatment, and a modest gain in the castration-resistant setting. But this was the premise for then saying, well, there is some activity from this drug. We should explore it in a more sensitive setting, in the newly diagnosed patients. And the other part of the Stampede 2 trial is looking at what you'd refer to as metastasis-directed therapy, which entertainingly has the TLA, or the mnemonic MDT, which is the same as the multidisciplinary team that we all use every week to discuss all patients with newly diagnosed prostate cancer. And there were a couple of key trials that explored metastasis-directed therapy. One was called STOMP, and the other one OREO. I quite enjoy those names. And they were in slightly different cancer situations, cancer settings, but the bottom line was they were looking at the role of high-dose stereotactic radiotherapy to low-volume metastatic, what you'd refer to as oligometastatic disease, so low-volume recurrences, either in patients who had previously had some treatment for their primary and then they'd relapsed, or in patients who were developing hormone-resistant disease. And essentially, both of these trials demonstrated that this was a therapeutic strategy worth exploring a bit further. If you can irradiate the visible disease on imaging, then you can potentially delay or keep people off hormonal treatment for longer and improve their long-term outcome. And this slide, top left, shows how the patients were androgen deprivation therapy free for longer if you had the targeted stereotactic treatment to the visible recurrences for patients. And indeed, there was a hint at a survival advantage as well in the overall survival curves. Now, these trials were small, randomized phase 2 trials, but low volume, low patient numbers. So to really get a proof of benefit, we wanted to do this in a larger patient group, and essentially in the newly diagnosed metastatic hormone-sensitive group. So that then brings us on to what is Stampede 2. So Stampede 2, going back to what I said right at the beginning, it's a different patient group. There's no longer the locally advanced high-risk group, but there are still two groups. That's patients with low volume and patients with high volume metastatic disease. So it's newly diagnosed patients with metastatic disease who are not on hormonal treatment. So we're assuming, therefore, that they are hormonally sensitive. Now, you can be a relapse after you've had localized disease many, many years ago, and now you've got metastatic disease, but there are rules about how long you were allowed to be on the hormone treatment for previously and what treatments you would have had in the past. But essentially, this is the flow chart of the trial. And if you have low volume metastatic disease at the time of your diagnosis, and a key message here is that the assessment of your metastatic volume is based on what we would refer to as conventional imaging, so bone scan and CT, because obviously the whole landscape has changed quite significantly with the development and the more widespread use of PSMA testing, PSMA PET scans. But the eligibility for Stampede 2 is based on conventional imaging, bone scan and CT. If you've got low volume disease, so less than 5 metastases, then your randomization is either standard of care or standard of care and SABR, stereotactic body radiotherapy, to the visible metastases. Now, again, I'll go back to that the emphasis I gave on what is standard of care. So standard of care could be what you would do locally. So that could be doublet treatment with enzalutamide. It could be doublet treatment with darolutamide. It could be triplet treatment with chemotherapy if you felt that those patients were going to benefit from the addition of chemotherapy as well. That's up to the individual clinician looking after the patient. But the trial experiment in that green part of the trial is either they get stereotactic radiotherapy to their 5 mets or they don't. Then you've got the pink flowchart on the right there, and that's for the patients who have more than 5 metastatic lesions. And in that group, there is the feeling that stereotactic treatment would not be sufficient, and let's use a different way of giving radiation to those more widespread metastatic lesions, and that would be with the PSMA lutetium treatment. But again, it's a randomized trial of a treatment that we don't know whether it's beneficial at this stage, so therefore not everyone gets it. You have to do a comparison with patients who are not getting it. So the randomization there would be that they get the standard of care, whatever that would be. And I guess in this group, there would be a greater use probably of chemotherapy as well as doublet treatments. And then there would be patients randomized to the lutetium treatment. They have to have visible disease on a PET scan. So interestingly, in this patient group, you put them in at this stage, you do a PSMA PET scan to make sure that their metastatic disease does take up PSMA, and then you randomize them to either the lutetium treatment or the standard of care. So the other 2 slides I had were just the lists of the eligibility criteria, but I'm not so sure that that's actually that interesting. So I'd probably stop the presentation there, and no doubt there'll be a number of questions. So I'll open it up to the floor if that works, Brian. Are you sharing, Brian, or is someone else?
Well, from a personal point of view, obviously you're my consultant, so I'm not expecting you to answer here at all, Angus. But from the information you've shown me there, from a personal point of view, I think I might be eligible for some of those treatments in Stampede 2. How does one become a candidate to go into the trial, and at what stage of the my situation would it be decided to admit me into the trial?
Well, so forgive me, Brian, but I can't remember the full details of because I know that your details go back many, many years, and the eligibility criteria will have an influence on someone's eligibility based on how much hormone treatment they've had previously, how much radiotherapy, what the radiotherapy was directed at, and indeed where is the metastatic disease now, if there is metastatic disease. So you have to have metastatic disease to be eligible for the trial. You have to be off hormonal treatment.
Yeah.
And just about to, and the recommendation is that someone's just about to start hormonal treatment, because that is their standard treatment for their recurrence or their newly diagnosed presentation of metastatic disease.
Right.
And in that situation, then, assuming they tick all the other boxes for the eligibility, then the amount of disease is measured, they're decided which part of the flowchart they go down, and then you randomize.
Okay. And is that's decided by the individual clinicians that that one would go to, or are there just a few clinicians that are able to admit to the trial?
No. There's I think we've got at least 2 or 3 consultants set up to do it. So myself, my colleague, Dr. Nick Pota, we've got a couple of locums working with us at the moment, so they won't be on what's called the delegation log, so the responsibility log for the trial locally in Sussex, but they would know about it and they'd refer patients to us if they felt that they were eligible.
Okay, right, thanks. Does anybody else have any questions they'd like to ask?
Thank you, Angus. That's really interesting. Yeah, yes, sorry. Claudia's my wife. I'm Dick Page, and I've got hormone sensitive metastatic disease. I was with Philip Savage and now with Will Croxford, your colleague
Yeah,
in Brighton.
yeah.
I've been treated with with first line, I call it hormone therapy for intermittent for some years now, Zoladex. And so what's the rationale with this trial about not being on hormone therapy? And can somebody like me, possibly in discussion with my oncologist, come off hormone therapy to go on the trial?
No, you have to be on hormone therapy in the trial.
Oh, you have to be.
Yes,
Oh,
everyone.
sorry.
Everyone. So the
Right.
basic premise is that all of these patients are metastatic hormone sensitive, and
Yes.
they're just starting their journey on hormonal treatment, on GnRH analog injections, Zoladex or Decapeptyl, or whichever one they're on.
Yeah.
Plus, usually these days, a second drug, an anti-androgen like enzalutamide or darolutamide.
Yes. But I'm definitely not just starting my journey. I've been on it since 2016 or 2015, on and off.
Yeah, yeah.
So people like me, so it's too late for people like me to go on this trial because I'm not starting out on the treatment.
I'm just going to look
That's
up.
fine. That's fine. I just getting my head straight about this.
So one of the eligibility exclusion criteria is more than 3 years of previous hormonal treatment.
Oh yeah, through more than 3 years, right? So that's a significant amount of time, and that would, and for what it's worth, that would exclude me. But that more than 3 years, it's not. It's. I mean, there will be a number of people who have been having it for a year or two, I suppose, who might be.
I mean, I think if you're on hormonal treatment and you are responding, then you're not eligible for the trial because you're on a gold standard treatment and it's working. Like all trials, they have quite strict criteria about the entry requirements, and you have to homogenize the group to a degree. You have to have the same sort of group of patients with the same stage of disease when you start the experiment. Yeah. So
Thank you.
They have rules about the duration of hormone treatment. That's okay.
Thank you.
Anybody else have any questions they'd like to ask? Something else, Angus, not on the Stampede trial. As you know, we do lots of drop-in sessions and support, given, sharing experiences with men that have recently been diagnosed or, want to come and share their experiences with us. One of the questions is what's the decision process as to which way a man should go, whether he has radiotherapy or prostatectomy, and also why would one man go on high-dose rate brachytherapy and another one go on low-dose rate brachytherapy, for instance? And what's the criteria that sort of sets that standard, which way they go?
So that sounds like a whole other presentation, probably lasting 40 minutes or an hour, to be honest. But in summary,
in simple terms,
yeah. Well, in summary, I'm afraid there is a group of patients. There's a stage of cancer which is genuinely suitable for 2 or 3 different options, and that's really tricky sometimes for patients to be offered different treatments with the knowledge that actually the cancer cure outcomes are essentially the same, but the side effect profile from all of those treatments is rather different. People like choice, but actually often in medicine and health, they don't necessarily want choice. They want to be told exactly what to do, or guided as to what we think is the most appropriate treatment. And there are definitely patients where we would say, no, I'm certain you should not have an operation and you should have hormone treatment with radiotherapy. But there is definitely a large cohort who are potentially suitable for 2 or 3 options, and then I'm afraid it is a question of gleaning as much information as possible and making a decision. In terms of I mean, you've got these stepwise options, haven't you? Go from surveillance, doing nothing and just watching it, to focal therapy, treating a small lesion within the gland, to whole gland therapy, which would include brachytherapy surgery and external beam radiotherapy, including what we've recently set up, which is the 5 fractions Sabre radiotherapy to the prostate, which is exciting, and that's maybe another talk for another time. And then you've got the patients with higher risk disease than that, who probably should be having a combination of hormone treatment for a couple of years, plus external beam, possibly plus a high dose rate brachytherapy boost. So just to answer one of your questions, low dose rate seeds is for low risk, organ confined. High dose rate boost is usually used in combination with external beam in much higher risk disease, but still regional, still localized. There you go. There's a 2-minute summary for a long complex.
Okay.
Can I just ask on a current topic? Lord Cameron, David Cameron's recently announced his diagnosis and treatment. I don't remember him coming to one of our PSA testing events for PCaSO, but
didn't ask me for an opinion either.
No.
Rude.
But I get the impression he's had the irreversible electroporation, the electric shock treatment of the cancer cells.
Yeah.
I don't know, that's classed as one of the focal treatments, which of course has reduced risk of side effects, which is obviously a win. To what degree is that sort of a useful tool, and is it available in our area?
Yes, it is available. Historically, I was referring them all up to Mark Emberton in London, but we've got a urologist in Sussex now, Mr. Zaki Khani, who's developing skills for focal therapy. It depends which part. It's getting into urologist territory from an oncologist perspective, but it depends in which part of the gland your lesion is as to which is the best option. HIFU is better for the lesions which are further posterior, so closer to the rectum, so you can point your ultrasound probe at a tumor quite close by. If it's near the front of the gland, so much further away, then you might need to do a different technique transperineally, for example, the IRE that you describe, or possibly there are other ones like cryotherapy and photodynamic therapy, those kinds of options.
Heard of photodynamic therapy. That's one we need to put into our Knowledge Empowers booklet.
Yeah, that was it must be about 10 or 12 years ago. There was a lot of news coverage about that because a Lancet article had come out from Mark Emberton at UCH. And I remember very clearly my old secretary, who subsequently retired, getting lots of calls from patients and relatives for a week or two after that paper came out. But it's another form of focal therapy. It's nothing particularly special about it. It's just a different way of doing it.
Thank you.
Angus, I have a question, if that's okay.
Of course.
I'm a patient of yours being looked after by Fiona that I'm really, really pleased with.
Oh, yeah.
She's excellent. I had cancer back in 2018. It came back 12 months ago, a year ago, and I'm now on enzalutamide.
Yeah.
Currently, I'm having a break of enzalutamide for 4 or 5 months, I think, because it's working extremely well. Are you of the opinion that it's safe to actually have breaks or to be on it permanently? And what are the advantages of actually having breaks?
So breaks would normally be reserved for people who are struggling with the toxicity of the drugs. Not because someone was doing so brilliantly well that they were told that you could just stop. You would stop because you're having side effects that are a struggle. But these days there are alternatives to the enzalutamide. Enzalutamide, as I said earlier, was the first one that came through. But there's quite a lot, as you may well have experienced, of fatigue and cognitive changes and memory changes and brain function issues that enzalutamide causes, which some of the newer ones like darolutamide and apalutamide don't cause as much. So you can switch between them. There are some more relaxed rules about switching drugs these days. But as a rule, we wouldn't necessarily just stop because it was working brilliantly and then restart, because you'd just carry on, and you'd carry on until it stops working.
Right, okay. I haven't, to be honest, I've been one of the lucky people that haven't really had any side effects at all from enzalutamide.
Great.
But I have been involved recently in a very serious car crash with multiple operations on my heart. And I think it was felt that maybe the enzalutamide was raising my blood pressure as one of the side effects and complications. That's the reason why I've been taken off.
Yeah, that sounds like a rationale. Yeah.
Yeah. What would you say is the normal time span for somebody on enzalutamide before it starts to wear off its effectiveness? I know that's an extremely difficult question.
No, it's not difficult. I mean, I can give you a figure which is based on the trials that were done, and it's a median, so the point in time where 50% of patients will have developed resistance. So it's just a point in time. It doesn't apply to any one person.
Okay.
It's about 3.5 years.
Okay. And then at that point, when that eventually happens, there are other options to look at that point.
There are.
Yeah.
Exactly. Yeah.
Yeah. All right. Thank you very much. Thank you.
I think we're just about there, are we now then? Brian, do you reckon we've
Yes, yeah.
covered it
Well,
all?
if everybody's happy.
Yeah.
That's
It's
great.
been
Thank,
yeah.
thank you once again for coming along, and
No problem. Thanks for the invite.
Yeah.
And
we're always really pleased to see you, especially as most of us know you.
yeah.
And we try to avoid asking personal questions. So, yeah, thank you very much
No
for coming along.
Thanks, guys. Have a good meeting.
Thank you.
Thank you. We do appreciate your support of PCaSO. Thank you.
No, not at all.